A very good evening, everyone. Thank you all for joining. So today we have Dr. Sakshi Arora ma'am with us. Today's session is going to be very, very important. So please be very attentive. The session is going to be conducted in two parts. First, ma'am will be discussing all the questions. And after that, if you guys have any query, just write it down in the comment box and ma'am will get back to you. Over to you, ma'am.
Hi, everyone. And it's so good to connect with you all again for the second session which we have. Now, today, you know that you were earlier also told that I'll be discussing MCQs on topics related to congenital malformation, amenorrhea, vaginitis, infertility, and genital TB. From all these topics, amenorrhea and congenital malformations, amenorrhea for clinical questions and congenital malformations for image-based questions, it's very, very important, right? So we are going to start the discussion very soon. And we'll start with question number 1. And yes, please, before I start the session, I don't know when these sessions would be uploaded. So it's better that you keep clicking pictures of these slides and these questions. Whatever slides I'm showing you, whatever questions we are discussing, take pictures of those slides and pictures of these questions, right? Okay, so question number 1, while evaluating a 30-year-old woman for infertility, you do a TVS and suspect a bicornuate uterus. You explain that additional testing is necessary and advise her to undergo following investigation of choice. So this patient, she came to you for infertility and you did a TVS. And that is when you suspected a bicornuate uterus. Now that is very important. That uterine malformations, they are always first, you get a first indication that a female has uterine malformations because either she's coming to you for infertility or she's coming to you for recurrent abortions and you do a TVS. So uterine malformations, the first investigation which tells you that a patient has any of these anomalies, any of these abnormalities or malformations is a TVS. And so was the case in this female. So I'm just seeing many of you are answering and you are saying option A, D, A. Okay. Some of you are saying it's D, some A, some C. So most of you believe it is going to be A, Siva is B, Disha B. Okay. So I can see many of you answering differently to this question. Now, this is something which I want to tell you. What is the investigation of choice and what is the gold standard investigation in these cases, right? Now, this same question was asked in a very different format in INI CT exam this year, which was held in 2021. The question which was given was, select the investigations which can help in diagnosis of unicornuate uterus. And the options given to you were 1 HSG, 2 laparoscopy, 3 phalloscopy, D X-ray. And you had, they had given you a combination. Option A was 1, 2, and 4. Option B was 1, 2, 3, and 4. Option C was 1 and 3. And option D was 1 and 2. So these are the kinds of questions which you get on investigations related to uterine malformations or Mullerian malformations. Now, what I want you to understand is, as I was telling you that congenital malformations and Mullerian malformations, they are detected first when a female complains of recurrent abortions or infertility. So the first investigation which tells you that this is a problem is either a TVS or an HSG. Right? So either you would have done a TVS or you would have done an HSG and you would have come to know that yes, your patient has got a Mullerian malformation or uterine malformation. Please understand that neither TVS nor HSG are investigation of choices, right? From HSG or from TVS, we cannot make a definitive diagnosis. The investigation of choice, very good, some of you are answering it correctly, is 3D ultrasound. That's the investigation of choice, right? Gold standard investigation is MRI. Now, if you are a Marrow subscriber, then you know these answers. If you are not a Marrow subscriber, and if you have learned anything other than this, you will have to remember what I'm telling you just now. This is what is the correct and the recent thing, that investigation of choice is 3D ultrasound and gold standard is MRI. What's the difference between investigation of choice and gold standard? बहुत सारे cases में you see this, that there are the investigation of choice also they give and gold standard also they give. See, gold standard means that you are going to do only if it is very necessary, right? But the most investigation of choice means which is going to give you the best diagnosis in the most cost effective manner and without being invasive to the patient, right? So most of the times they ask you investigation of choice. Unless and until they ask you which is the gold standard investigation, you are not going to answer the gold standard investigation, right? Like your moms, like your sisters, they keep their gold in a locker, right? They don't use it that oftenly. Similarly, gold standard investigation is the one which is not used oftenly. It is kept in a locker that if needed, we will use it, right? Now, the other investigation which may help in diagnosis of uterine malformation is when you look at the uterus from inside as well as from outside, and that is laparoscopy plus hysteroscopy, right? So with the help of laparoscope, you can look at the uterus from outside. You can see the fundus of the uterus, so you can come to know how it is. And hysteroscopy will tell you if a septa is present inside or not. But then these are invasive procedures, so they are not done routinely, but yes, they are helpful in diagnosis, right? So please click a picture of this and keep it with you. This is very, very oftenly asked question, right? So in this question number 1, the investigation of choice is 3D ultrasound, right? Now in question 1B, which was the question which was asked in INI CET, HSG, yes, it is helpful in diagnosis. Just now we saw it's the first investigation. Laparoscopy, yes, it helps in diagnosis. Phalloscopy, what is phalloscopy? Phalloscopy is when you look inside the fallopian tube, right? So when you are looking inside the fallopian tube, that is what is phalloscopy. So phalloscopy doesn't help in diagnosis of uterine malformations. Similarly, X-ray doesn't help in diagnosis of uterine malformations. So the correct options here are option 1 and option 2. In other words, option D, right? So these are questions which will be asked related to investigations, right? Then the other kind of questions which they can ask you on congenital malformation is this question. In the same question, you also explain her that additional testing is also necessary because of women's increased risk of congenital anomalies in which organ system, right? So because of which organ system you need to evaluate which other organ system. Yes, and all of you are right. It's option C. One of you said it's D. That is wrong. See, Mullerian duct also leads to the formation of renal tract, some parts of the renal tract, right? So if there is Mullerian malformation, there are chances that there will be renal malformations also. In other words, urinary malformations also. So the answer here is option C. So please remember, in all cases of Mullerian malformations, it is essential to rule out renal anomalies. And how are you going to rule out renal anomalies? By doing X-ray KUB or by IVP, intravenous pyelography, right? X-ray KUB and IVP will not tell you about the Mullerian malformation. It will tell you whether there is any associated renal anomaly present or not. In all Mullerian malformations, renal anomalies are seen except in case of, in which condition do you not see do you not see renal anomalies? Quickly, I want answers from all the Marrow subscribers. Excellent. Excellent test, Pandey. Yes, and Sambhavit. Very nice. It is not seen in case of diethyl stilbestrol exposure in utero in females. So if there is a female child who had in utero exposure to diethyl stilbestrol, then many anomalies would be seen. Like many of you were saying, yes, a T-shaped uterus will be seen, hypoplastic uterus will be seen, right? You will also see cancers, like you will see adenocarcinoma of the cervix, clear cell carcinoma of vagina, right? But you will never see renal anomalies. But this is only in females. If diethyl stilbestrol exposure occurs in males in utero, then renal anomalies are seen, right? Is that clear to all of you? Then please remember, suppose there is a case of Mullerian agenesis. What do you understand by this term Mullerian agenesis? That is, both the Mullerian ducts are absent. And this person also has, this female also has renal anomalies like renal agenesis or horseshoe-shaped kidneys, plus skeletal anomalies, right? Skeletal anomalies related to cervical vertebra are more common. This is what is called as MRKH, Mayer-Rokitansky-Kuster-Hauser syndrome. Mayer-Rokitansky-Kuster-Hauser syndrome, right? So these are additional questions which they can ask you on congenital malformations. And the third variety of questions which they can ask you on congenital malformations are image-based questions, right? So over here in question number 3, the question is identify the uterine malformation suspected from the HSG. Right now, any uterine malformation can be given to you and its HSG can be given, and you will have to identify that uterine malformations. Right now, like question 3 and question 4, both of them I have chosen related to image. Now, I know all of those who are Marrow subscribers, these images are very easy for you. We have done them in our classes as well, in the videos also. But all those who are attending to my lecture for the first time, see, this is how a normal HSG appears. Right? What is HSG? HSG is when, with the help of this special cannula is called as Leach-Wilkinson cannula. Now, with the help of this Leach-Wilkinson cannula, and you have to concentrate on its tip. Do you see it's a funnel-shaped tip? Funnel-shaped tip? Yes. So with the help of this cannula, a radio-opaque dye will be passed into the uterus, and this will be followed by serial X-rays. And that this is a normal image which you are getting. This is the shadow of Leach-Wilkinson cannula. This is present in vagina. This is a single cervix. This is uterus. These are the two tubes, right? And from the tubes, what you can see, these are the tubes, right? And from the tubes, you can see that the dye is spilling. So this is how a normal HSG appears. Now, whenever you get an image on HSG and you have to identify Mullerian malformation, this is the sequence which you are going to follow and you will come to the diagnosis. So number 1, I want all of you to see the number of fallopian tubes in the image, right? If there is one fallopian tube, there is only one condition in which you get one fallopian tube, and that condition is unicornuate uterus. So if you are getting one fallopian tube on HSG, it means it has to be a unicornuate uterus, right? If you are getting 2 fallopian tubes, then go to the next step. Next step is count the number of Leach-Wilkinson cannulas which you see in the HSG. Yes, and all of you are right, because I'll show this image that in uniconnovate uterus, you will get a banana-shaped uterus. See over here. Can you see a single fallopian tube? Right? So if you are getting a single fallopian tube and you are getting a banana-shaped uterus, it has to be uniconnovate. Right? Now, suppose you are getting 2 fallopian tubes, then go to the next step. The next step is count the number of Leach-Wilkinson cannulas which you are seeing in the HSG. If you are getting 2 Leach-Wilkinson cannulas, that means this female has 2 cervix, and that is why I need 2 cannulas to be inserted. And there is only one condition in which you get 2 cervix, and that is uterus didelphus. In uterus didelphus, you get 2 fallopian tubes, 2 halves of the uterus, 2 halves of the cervix, and vagina may be single or you may get 2, right? The differentiating factor is 2 cervix. Because 2 cervix are present in didelphic uterus, it means that it has to be uterus didelphus, right? Now, if you are getting a single HSG cannula, then it means I have to focus either on bicornuate or on septate uterus, right? And how am I going to differentiate between the two on HSG? If on HSG, the angle between the 2 horns of the uterus, so this over here are the 2 horns of the uterus which I have drawn, and this orange color is the angle between them, right? So if the angle between the 2 horns of the uterus is more than 60 degrees, or if the distance between them is more than 4 centimeters, then it is more likely to be a bicornuate uterus. On the other hand, if the angle between the 2 horns is less than 60 degrees and distance between them is less than 4 centimeters, it's more likely to be a septate uterus. So this is how you come to know whether you are looking at the image of uniconnovate or you're looking at the image of didelphus, biconnovate, or septate uterus, right? So with this background, I want you to look at this image. Now, in this image, what are you seeing? In this image, you are seeing this is one fallopian tube. Over here, this is the other fallopian tube. So I'm getting 2 fallopian tubes. Next thing I have to look is how many Wilkinson cannulas, Leach-Wilkinson cannulas. So you are getting 1 cannula and 2 cannula. The only condition in which you get 2 cannulas is uterus didelphus. Uterus didelphus. So this image is of uterus didelphus. Clear? Now I want all of you to understand what I meant when I say angle between them is more than 60 degrees and a distance between them is more than 4 centimeters in biconnovate uterus. So look at this HSG over here, right? This HSG, which I'm saying is image A. In image A, the first thing what you have to see is the tubes. So 1 tube and 2nd tube. So it cannot be uniconnovate, right? Then look at the number of cannulas. I'm just having a single cannula, so it cannot be didelphus. Now, either it has to be biconnovate or it has to be septate. So now I am going to see the angle between the 2 horns. This angle is more than 60 degrees and distance is more than 4 centimeters. So image A most probably belongs to a biconnovate uterus. On the other hand, if you look at image B, in image B, the angle between the horns is less than 60 degrees and distance is less than 4 centimeters. It has to be a septate uterus. Now, sometimes in order to confuse you, instead of giving you HSG images, they can give you images like this and they can ask you identify. So in this case, I want you to understand first that how many uterus cervix are you seeing over here, right? So what I am seeing over here is 2 uterus and a single cervix, single vagina. Because there is a single cervix, it cannot be didelphus, right? So it has to be either biconnovate or it has to be septate. Now, in order to differentiate between biconvate and septate, you have to look at this external contour. If external contour is abnormal, it has to be biconvate, right? So image A1 is again an image of biconvate uterus. I want you to understand this very carefully. This is one half of the uterus. This is second half of the uterus. This is cervix. Single cervix, two uterus means either biconvate or septate, right? Now what you have to look at is the external contour. In biconvate uterus, external contour is abnormal. Fundus में dipping मिलती है. You will get a dipping in the fundus, right? Whereas if you see a septate uterus, that is image B now, B1. Look at this image. Now in this image, you are getting two halves of the uterine cavity, and you are getting a single cervix and a single vagina, right? So two uterus, single cervix, single vagina here also. Now, why am I saying it is septate? Is because look at the external contour. External contour, absolutely normal, means it has to be septate uterus, right? So they can give you to differentiate biconvate and septate in the form of HSG or in the form of images. In images, you have to look at the top of the uterus, the fundus of the uterus. If fundus of the uterus is showing a dip, if fundus of the uterus is abnormal, it is biconvate. If fundus of the uterus is appearing absolutely normal, it has to be a septate uterus. Clear to all of you? Yes? Okay. Now, with this concept, look at question number 4. Again, you have to identify the uterine malformation. Now, again, you are going to follow the sequence which I have told you. 1 and 2 fallopian tubes. Because it is 2 fallopian tubes, it cannot be uniconvate, right? Single Leach-Wilkinson cannula, so it cannot be didelphys. Now I have to look at the angle between the horns. The angle between the horns is less than 60 degrees and distance is less than 4 centimeters. And all of you are saying correctly, it is septate uterus, right? But please remember, HSG is not the best method to differentiate between septate and biconvate, right? Best investigation or investigation of choice is 3D ultrasound and gold standard is MRI. Now, when am I going to do surgery on a congenitally malformed uterus? I am going to do surgery only if it leads to 3 or more than 3 abortions. So if a septate uterus or a biconvate uterus is leading to recurrent abortions, then I'm going to do surgery. Otherwise, I'm not going to do surgery. Surgery for septate uterus is, what is the surgery for septate uterus? Tell me. So surgery for septate uterus is hysteroscopic resection of the septa. So you just have to remove the septa hysteroscopically. And what is the surgery for biconvate uterus? For biconvate uterus, it is metroplasty, Tompkins metroplasty. Clear to all of you? Right? So these are all the questions which they can ask you on congenital malformations. Okay. Then coming to question number 5, which is coming on a very, very important topic, that is amenorrhea. Pushpa, I will answer your question, but after the session is over, right? A mother brings her daughter in to see you for consultation. Daughter is 17 years old. So she's 17 years old and has not started her period, right? That means she's a case of delayed puberty or primary amenorrhea. Well, how do you define primary amenorrhea? Primary amenorrhea is defined if by 13 years of age, a female doesn't have menstruation in presence of secondary sexual characteristics, or by 15 years of age, irrespective of secondary sexual characteristics. So this is 17 years and she has not had a period, right? So she has to be a case of primary amenorrhea or delayed puberty. She is 4 feet 10 inches tall, right? That means, is it normal height? No, she is a little short statured. Then she has no breast budding, On pelvic examination, she has no pubic hair. By digital examination, cervix and uterus are present. Ovaries are not palpable. As a part of workup, FSH and LH levels are drawn and both of them are high. Which of the following is the most likely reason for delayed puberty and sexual infantilism in this patient? Now, whenever you are reading MCQs, which are clinical MCQs, you have to highlight those points which you have to focus on, right? Okay, so now tell me, what do you think this female is having? Now, all of you, most of you rather, I would say, are answering this question correctly. Some of you are making a mistake, and for all the students who are, a little bit confused in topics related to primary amenorrhea, quickly, I'm going to tell you how to come to a diagnosis in cases of clinical amenorrhea when you get a clinical question. This is a very, very important flowchart. I want all of you either to take a picture or to copy this, right? So in primary amenorrhea, whenever a question comes to you, first thing you have to see in the question whether they have given secondary sexual characteristics are present or secondary sexual characteristic is absent. When we talk about secondary sexual characteristics, we are talking about breast basically. So you have to see what have they given in the question, breast present or breast absent. Now, if breast is present, the second thing which you have to see is uterus is present or uterus is absent. If breast is also present and uterus is also present, then it means there is an obstruction in the outflow tract. The female is menstruating normally, but her blood, her menstrual blood is unable to come out. Why? Because of obstruction in the passage, and that is what is called as cryptomenorrhea. And an example of cryptomenorrhea is imperforate hymen. So this means in this female, there is her hymen is imperforate, because of which blood is unable to come out. In these cases, you will get typical history of cyclical pain in abdomen from the patient. So patient will say that every month she has cyclical pain in abdomen, but menstrual blood doesn't come out, right? And when you will do a local examination, you will get a bluish, tensed, bulging hymen. So if you are getting these pointers in your question and your question says that secondary sexual characteristics are present and uterus is present, it has to be cryptomenorrhea. On the other hand, if your question says secondary sexual characteristic present, that is breast present but uterus absent, it could either be a case of Mullerian agenesis or it could be a case of androgen insensitivity syndrome, right? How am I going to differentiate clinically between them? Clinically, in your questions, in Mullerian agenesis, they will say, apart from this, that the secondary sexual characteristics are present and uterus is absent, the question will say that breast is well developed and pubic hair and axillary hair are well developed. Because in androgen insensitivity syndrome, only breast is well developed, pubic hair and axillary hair are less developed. And this they can say also in the form of Tanner staging. They can say that breast is Tanner stage 4 or 5 and pubic hair belongs to Tanner stage 1 or 2. Tanner stage 4 and 5 means well developed and Tanner stage 1 and 2 means scanty, right? Apart from this, in Mullerian agenesis, they may give you that it is associated with renal anomalies. And what is the karyotype? Karyotype is 46XX. In case of androgen insensitivity syndrome, they are 46XY. In other words, they are males. So they will have gonads, which are testes, and their testes will be undescended. They will have undescended testes as their gonads. And these undescended testes can present to you in the form of inguinal hernia. So whenever they say that there is a female in whom inguinal hernia is present, uterus is absent, secondary sexual characteristic breast is well developed, but pubic hair is scanty, it has to be androgen insensitivity syndrome. Are you understanding? So the best way to differentiate Mullerian agenesis and androgen insensitivity syndrome is karyotyping, but clinically also you can differentiate. Clear to all of you? Now comes the second category. Second category is if a female is coming to you with primary amenorrhea with absent secondary sexual characteristics. Now, whenever a female comes to you with secondary sexual characteristics absent, in all the conditions which we are going to discuss, uterus will be present, right? But it will be hypoplastic. It will not be very well developed. It will be present, but it will not be well developed in all the cases, right? Now, so uterus cannot be the differentiating feature, because in all these differential diagnoses, uterus is present and it is hypoplastic. Now I have to look at the height of the patient. If in the question the height is short, then they are talking about Turner's syndrome, that is 45XO. In Turner's syndrome, gonads are streak ovaries, right? Just now we will also discuss that for presence of ovaries, Y chromosome should be absent, right? But for proper development of ovaries, both X chromosomes are needed. So I'm repeating, for presence of ovaries, Y chromosome should be absent. Only if Y chromosome is absent, then ovary will be a gonad. If Y chromosome is present, gonad will be testes, right? But for proper development of ovaries, both X chromosomes are needed. So in Turner's syndrome, because chromosome number is 45XO, that is Y chromosome is absent. So gonad has to be ovaries. But because only one X chromosome is present, this ovary will not be well developed and you will get streak ovaries. Please remember, this streak ovary is not going to produce enough estrogen, and that is why secondary sexual characteristics are absent in Turner's syndrome, right? Also, streak ovaries, they never become malignant. So you don't have to remove the streak ovaries. Clear? Now, because estrogen is less in these females, so obviously negative feedback on FSH won't be there. So there will be increased LH and increased FSH, right? Now, if height of the patient is normal, it can be a case of Swire's syndrome. Swire's syndrome is 46XY, right? In Swire's syndrome, height of the patient is normal. Please remember, Turner's syndrome and Swire's syndrome both come under a broad category of gonadal dysgenesis. So when I say patient has gonadal dysgenesis, it could either be Turner's syndrome or Swire's syndrome. And just now I told you, whenever there is Y chromosome present, gonads have to be testes. So in this case, the gonads are testes which are undescended. So they are males with undescended testes, right? But yes, in these males, uterus is present. As I told you, in all these conditions, uterus is present. Now, undescended testes, they undergo malignancy and they have to be removed. So in Swire's syndrome, also you have to remove the testes, gonadectomy. And in androgen insensitivity syndrome, also you have to remove the testes, you have to do a gonadectomy, right? Clear to all of you? The other thing which you have to remember is, in androgen insensitivity syndrome, gonadectomy will be done around 14 to 16 years of age after breast development is complete. But in Swire's syndrome, gonadectomy will be done as soon as the diagnosis of Swire's is made. So at whatever age you are making the diagnosis of Swire's, as soon as you make the diagnosis, you do a gonadectomy in Swire's syndrome. In androgen insensitivity syndrome, you wait till 14 to 16 years of age so that the breast of the female develops and then you do gonadectomy, right? Clear? Then a third condition, which could be when secondary sexual characteristics are absent and uterus is present and height is normal. It could be Kalman syndrome. Now, what happens in Kalman syndrome? In Kalman syndrome, there is hypothalamic failure, right? That means GnRH is absent. So obviously, if GnRH is absent, so LH has to be absent, right? FSH has to be, LH has to be decreased, FSH has to be decreased, and estrogen has to be decreased because GnRH is less. And again, in this condition, you will get hypoplastic uterus. The additional feature which you get over here, which is very, very significant, is anosmia. So if your question says anosmia is seen, it means it has to be Kalman syndrome. Clear to all of you? Is this chart clear? Okay. Now with this background, go and solve this question. So this is a 17-year-old female who has come to you with amenorrhea. Her height is short. No pubic hair and breast budding is present. No breast budding present means secondary sexual characteristics absent, right? Uterus present. Ovaries are not palpable. LH and FSH are drawn and they are high. So did you see over here that in gonadal dysgenesis, conditions which are there in gonadal dysgenesis, whether it is Turner's or whether it is Swire's, FSH and LH are high. But in Kalman syndrome, LH and FSH levels are low. So Kalman and Turner's and Swire's, they can be differentiated based on LH and FSH. Clear to all of you? In Kalman, LH and FSH will be low. In Turner's and Swire's, LH and FSH will be high. Now you will ask me, ma'am, how will we differentiate Turner's and Swire's, right? Now, in case of Turner's, height will be short. You will get additional features like webbing of neck, shielding of chest, short fourth metacarpal, cubitus valgus. All these things you get in Turner's, which you do not get in Swire's. Right? Turner's, the chromosome number is 45XO. Swire's, the chromosome number is 46XY. Right? Clear? So over here, the answer is, because LH and FSH levels are high, your answer becomes gonadal dysgenesis. Right? It is not testicular feminizing. Why? Testicular feminizing is androgen insensitivity syndrome. In androgen insensitivity syndrome, breast development is present. It is not McCune-Albright syndrome. McCune-Albright syndrome, it is a reason for precocious puberty and not for delayed puberty, right? You get cafe au lait spots and you get precocious puberty. Kalman syndrome, why not? Kalman syndrome, because the levels of LH and FSH, they have to be decreased in Kalman syndrome. Why not Mullerian agenesis? Because in Mullerian agenesis, breast development will be present. Proper breast development will be present. Clear? Yes? No, Samiksha. That was, it was a mistake and I have corrected it there. In Kalman, in Swire's, in Turner's, uterus is present in all these three conditions. Uterus is present, but it is hypoplastic in all these three conditions. That was by mistake I had written there and I had just cut it while I was teaching, right? Now I want you to make this table. This is a very, very important table for primary amenorrhea, where I have written condition, karyotype, secondary sexual characteristics, uterus present or absent, and the levels of LH and FSH, right? Many times they are asking you questions based on levels of LH and FSH. This table will be very handy if you take a picture, right? Let me quickly explain you. Mullerian agenesis, karyotype is 46XX, right? In Mullerian agenesis, secondary sexual characteristics are present. Uterus is absent. LH and FSH will be normal, right? Because over here, the ovaries are normal. So estrogen will be normal. So negative feedback on LH and FSH would be present. And so LH, FSH, estrogen, everything is normal, right? In androgen insensitivity syndrome, which is 46XY, breast will be present, but scanty pubic hair will be there. Uterus will be absent. The levels of LH will be high and FSH will be normal. So remember, in androgen insensitivity syndrome, you get a picture similar to PCOS. In PCOS also, the levels of LH is high and FSH is normal. Similarly, in androgen insensitivity syndrome, also the levels of LH are high and FSH is normal, right? In Turner's syndrome and in Swire's syndrome, in Turner's syndrome, karyotype is 45XO. In Swire's, it is 46XY. In both these conditions, secondary sexual characteristics are absent. You get hypoplastic uterus, and in both these conditions, LH and FSH will be high. In Kalman syndrome, chromosome number is 46XX. Secondary sexual characteristics will be absent. Uterus will be present. It will be hypoplastic, but the levels of LH and FSH will be low. right? So I hope you all are understanding. Yes? Okay. Now, look at this question. A 19-year-old patient presents to your clinic with primary amenorrhea. She has normal breast and pubic hair development, but uterus and vagina are absent. Which of the following karyotypes you expect in this patient? Right? So primary amenorrhea, breast development is normal, pubic hair is normal, uterus is absent. So just now I told you, if it is primary amenorrhea with breast development and pubic hair development normal and uterus absent, it has to be Mullerian agenesis. And Mullerian agenesis is 46XX. Clear to all of you? Now, before we go ahead from this question, just a small thing. Remember that differentiation of gonads, it depends on Y chromosome. On the distal end of short arm of Y chromosome, so on the distal end of short arm of Y chromosome, there is a gene present, which is called as SRY gene. And it is this SRY gene which is going to decide whether the gonads will be testes or whether the gonads will be ovaries. If SRY gene is present, in other words, Y chromosome is present, the gonads will be testes, right? If SRY gene is absent, or that, in other words, Y chromosome is absent, then the gonads will be ovaries, right? For proper development of ovaries, as I told you, both X chromosomes are needed, right? So please remember that Y chromosome absent means ovaries will be present. But in that case, for proper development of ovaries, you need that 2X chromosomes for proper development, right? Presence of ovaries depends on absence of Y chromosomes. Clear? Now, for breast development, you need estrogen. And for pubic hair and axillary hair development, you need androgen. Right? Okay. With this background, look at the previous question again. In 45XO, because Y chromosome is present, that is why gonad will be ovary. But will it be well developed? No, it will not be well developed. It will be streak ovary. And streak ovary will give decreased estrogen. So breast and pubic hair will not be present. Ovary say not only estrogen comes out, androgens also come out from ovary, right? So breast and pubic hair will be absent. 46XX, just now we said 46XX means normal ovary. Normal ovary will mean normal estrogen, and normal estrogen will mean normal breast development and pubic hair development, because ovary will release androgens also. 46XY again means that it is testes, right? And from testes, testosterone will come out, right? And 46XXY means testes, and from testes, testosterone will come out. In 46XY, if these males, they are resistant to testosterone, right? Because if these males are resistant to testosterone, what is going to happen? Then this entire testosterone will be converted into estrogen with the help of enzyme aromatase, and that is what leads to breast development. But because they are not sensitive to testosterone, they are resistant to testosterone, so pubic hair will be absent, right? That is exactly what happens in androgen insensitivity syndrome. In androgen insensitivity syndrome, there are normally functioning testes. So they will produce testosterone, but these males are resistant to testosterone, right? Clear to all of you? Next question. Question number 7. A 15-year-old female presents with inguinal hernia. She has not attained menarche yet. Her breast development corresponds to Tanner stage 4, but has no axillary or pubic hair. The most likely diagnosis is, Now, if a female is coming to you with inguinal hernia, that means what is present? Gonads mein testes. Right? So either she has, so this means she is 46XY. So either she is androgen insensitivity syndrome or she is Swyer's syndrome. How do you differentiate between the two? In androgen insensitivity syndrome, breast development is present, pubic hair development is absent. But in Swyer's syndrome, breast is also absent, pubic hair is also absent. In androgen insensitivity syndrome, uterus is absent. In Swyer's, uterus is present. So write it properly. Uterus is present. Clear to all of you? So this is a typical way in which they ask you that there is a female who comes to you with inguinal hernia, Tanner stage 4, axillary hair absent. It means it has to be androgen insensitivity syndrome or testicular feminizing syndrome. Right? Questions on primary amenorrhea are very, very important. And with this chart, which I have given you, this chart, this flow chart, and the differences between androgen insensitivity and Swyer's syndrome, right? You will be able to solve any question. Mixed gonadal dysgenesis will not be asked, right? So don't worry. Mixed gonadal dysgenesis, they're not going to ask. Clear? Then comes a 35-year-old lady is not having menses for last 4 months, right? This means she's a case of secondary amenorrhea. She has high FSH and LH levels with low estradiol. The likely cause is, you have to tell the likely cause: panhypopituitarism, Kalman syndrome, premature menopause, PCOS, or exogenous administration of estrogen. And I'm very happy to see that maximum of you are answering it correctly. Right? Now, like we had drawn tables for primary amenorrhea based on LH-FSH, similarly, we are going to draw tables for secondary amenorrhea based on LH and FSH. One thing which I want to tell you all, yahan pe to they've given you high LH-FSH levels. Sometimes they may give you a value. So remember that normal value of FSH and LH is between, it is up to 10. Up to 10 milli international units. That is the normal value, right? So if it is more than that, then it is more, or it can be, if it is 1 to 2, then it is low normal. 1 to 2 is low normal, and up to 10 is the normal value, right? Okay. So whenever you get a question or a female who comes to you with secondary amenorrhea, the first investigation which you have to do is a urine pregnancy test. And this algorithm you have to remember, right? Then first, yes, pregnancy is the most common cause of secondary amenorrhea, but please do not forget that pregnancy may also lead to primary amenorrhea. Now you may ask me, ma'am, how? Because there will be cases of incest, right? These females might have been, sexually abused by their father or by their brother. And when they attain menarche, before their first period comes, they become pregnant. And such females are never going to come and tell you that they have incest. So in primary amenorrhea also, you should do urine pregnancy test. In secondary amenorrhea, you have to do, but in primary amenorrhea also, you have to do a urine pregnancy test, right? Then the next step which you have to do is you have to do hormonal assessment, in which you are going to measure TSH levels, prolactin levels, LH and FSH levels, right? Because thyroid problems can lead to secondary amenorrhea, increased prolactin levels can lead to secondary amenorrhea, and LH and FSH you have to check, because based on LH and FSH, so many diagnoses will be made, right? After doing this, then you are going to do a progesterone challenge test, in which you give progesterone for 4 to 5 days, and then you stop. Right? And if after giving progesterone for 4 to 5 days and after stopping, if bleeding is present, that means the test is positive, and that means your diagnosis is PCOS. So if your question is saying that progesterone challenge test is positive, then the diagnosis is PCOS. After progesterone challenge test, we go for estrogen plus progesterone challenge test, in which we are going to give estrogen and progesterone for 21 days, like a normal menstrual cycle, and then stop. Now, if estrogen and progesterone challenge test comes out to be negative, then that means no bleeding is present after stopping. Then that indicates it is a case of Asherman syndrome. And even after doing this much, if you cannot make a diagnosis, go for MRI of the brain, right? So first is urine pregnancy test. Next is hormonal levels, TSH levels, prolactin levels, LH and FSH levels. Then do a progesterone challenge test. If progesterone challenge test comes out to be positive, it has to be PCOS. If estrogen and progesterone challenge test come out to be negative, then it is Asherman syndrome, and then go to MRI brain, right? Now let me explain you all the different conditions and of secondary amenorrhea, which they may ask, and at what level the problem is, right? So first is Asherman syndrome. Asherman syndrome can lead to secondary amenorrhea. This is very, very important table. In Asherman syndrome, problem is at the level of endometrium or uterus. And what is the problem? There are adhesions inside the uterus. Because over here, ovary is normal. Because ovary is normal, so LH and FSH will be normal, because negative feedback on LH and FSH will be normal. Ovaries be normal hai, hypothalamus normal hai, pituitary normal hai. So they are released normally, and the negative feedback is also normal. So LH and FSH are normal. In question, they may give you that patient has history of abortion or a history of curettage, or she has history of genital TB, right? That means if they're saying this much, it means it's a case of Asherman syndrome. And just now I told you one more important point which they will give you is that estrogen and progesterone challenge test is negative. The moment they say all these things together, you know it is a case of Asherman syndrome. Then it could be a case of premature menopause, right? Or premature ovarian failure, which is happening at less than 40 years. Now, problem or level is at the level of ovary, right? Now, when the problem is at the level of ovary, so the level of estrogen will be decreased. So negative feedback on LH and FSH is gone. Because negative feedback on LH and FSH is gone, so both LH and FSH levels are high. And how much high? If they are more than 20, you suspect. But if they are more than 40, you confirm that it's a case of premature menopause or ovarian failure, right? Then the third problem related to ovary could be PCOS. In PCOS, the levels of LH are high and the levels of FSH are normal. And you are going to get hirsutism, right? Fourth problem could be a prolactinoma. What is a prolactinoma? A prolactinoma is a prolactin secreting pituitary tumor. Now, because it's a prolactin secreting pituitary tumor, so over here in this case, prolactin, it has a negative feedback on GnRH. Because it has a negative feedback on GnRH, so levels of LH and FSH will be low. Please remember, if there is any problem in pituitary or any problem in hypothalamus, always the levels of LH and FSH will be low. If there is any problem in ovary, the levels of LH and FSH are high, right? Now, because the levels of LH and FSH are low, and in how are you going to know whether it is prolactinoma or whether it is Sheehan? In prolactinoma, patient is going to give you history of galactoria. There will be milk secretions coming from the breast. Because prolactinoma is a pituitary tumor, the patient complain karegi headache. The patient will have headache and visual symptoms. And when you will do an MRI, you will see a pituitary tumor, right? In Sheehan syndrome, what happens? In Sheehan syndrome, there is anterior pituitary necrosis. As I told you, no matter what is the problem in pituitary or hypothalamus, the levels of LH and FSH have to be low. So here also the levels of LH and FSH are low. Because Sheehan syndrome happens due to excessive PPH. It happens after excessive blood loss. So patient is going to give you history of failure of lactation after delivery, right? So if in your question you get there is failure of lactation after delivery, it has to be Sheehan. And on MRI, you are going to get empty sella turcica. In hypothalamus problems like anorexia, exercise, LH and FSH levels will be low, but the MRI will be normal. So this is how you can differentiate all causes of primary amenorrhea, of secondary amenorrhea. LH-FSH normal hai, it has to be Asherman syndrome. LH-FSH high, it has to be premature ovarian menopause. In PCOS, LH is high, FSH is normal, right? LH-FSH low, it has to be problem in pituitary, which could be prolactinoma, which could be Sheehan syndrome, or it could be a problem in hypothalamus. All these three can be differentiated based on specific symptoms and based on MRI. Clear to all of you? Yes. So now look at this question. In this question, LH and FSH levels are high, right? So it has to be a cause related to ovary, right? So either it has to be premature menopause or PCOS. In PCOS, LH is high, FSH is normal, right? Whereas in premature menopause, LH high, FSH high, right? So this is a case of premature menopause. Clear to all of you? Yes. Now, look at question number 9. A 35-year-old mother of 2 children, Radha, who's 6 years old, Lalit, who's 4 years old, is suffering from amenorrhea for last 12 months. She has history of headache, blurred vision, and galactorrhea. Most appropriate investigation in her is. So if your female is giving you history of galactorrhea, headache, blurred vision, and amenorrhea, it means it is prolactinoma. Very good, all of you. Proud of you. So what are you going to do? You are going to measure the levels of prolactin, right? Very nice. Now, drug of choice for prolactinoma. Please remember that if they simply ask you drug of choice for prolactinoma in a non-pregnant female, right? Then you have to say it is cabergoline. Very, very important. These days, they're asking you integrated topics. So they will ask you this question and they will ask you the drug of choice, right? That is how they will integrate pharmacology and obstetrics. If they ask you, there is a non-pregnant female who's complaining of infertility and she has a prolactinoma, then the drug of choice is bromocriptine, because bromocriptine can lead to ovulation induction, right? So in an infertile female, it is bromocriptine. Now, if they ask you that there is a pregnant female with prolactinoma, what is the drug of choice? You are going to say it is conservative treatment, no management. In pregnancy, we do not give bromocriptine, we do not give cabergoline, right? We are just going to do wait and watch for a prolactinoma, just a follow-up and nothing else, right? Treatment has to be given in pregnancy only if patient is complaining of visual symptoms. If patient says she's having visual symptoms, then only you are going to treat prolactinoma in pregnancy, and then the drug of choice will be bromocriptine. Are you understanding, all of you? Otherwise, in pregnancy, we do not treat prolactinomas, right? Okay. Question number 10. A patient had spontaneous abortion, and then she came with amenorrhea, and FSH levels is 6 international units per liter. What is the most appropriate diagnosis? Option A, ovarian failure. Option B, pregnancy. Option C, uterine synechia. Option D, pituitary failure. Why are you getting confused, all of you? Many of you are giving wrong answers. Why? Tell me. 6 international units. Is it normal or not? I told you range is between 1 to 10. 1 to 2 is low normal. So 6 means it is normal, right? So if you are getting normal LH-FSH, how can you think it to be a pituitary failure? In pituitary failure, just now I told in pituitary causes, LH and FSH are low. Someone just now said ovarian failure. Baba, if it is a case of ovarian failure, just now I told you in ovarian failure, LH and FSH levels will be high. So it cannot be ovarian failure. It cannot be pituitary failure. And just now I told you, if you are getting normal levels of LH and FSH, it has to be Asherman syndrome. And what happens in Asherman syndrome? Additions are present inside the uterus, uterine synechia, right? So this is a case of Asherman syndrome. The correct answer is Asherman syndrome. Now, many of you are saying pregnancy also. What happens in pregnancy? In pregnancy, there is increased estrogen, increased progesterone. Because there is increased estrogen, estrogen has a negative feedback on FSH. So the levels of FSH are low in pregnancy. Because it has increased progesterone, progesterone has a negative feedback on FSH, on LH. So the levels of LH are low. So in pregnancy, levels of LH and FSH are low. Please remember. Clear to all of you? And here they are telling you there is history of abortion. Just now I told you that whenever there will be a Asherman syndrome, patient will give you history of abortion or curettage or genital TB. These tables which I'm teaching you, they are very important for your MCQ solving, right? Then this again is an INI CET 2021 question. You have to match the hormone levels, right? Tell me, in case of Asherman syndrome, how will the LH and FSH be? Just now we did. LH and FSH will be normal, right? In case of ovarian cause, whenever there is an ovarian cause, what happens to LH, FSH? Whenever there is ovarian cause, LH and FSH increase, right? What happens in PCOS? In PCOS, LH is high, FSH is low normal. What is Sheehan syndrome? Pituitary causes. Whenever there is a pituitary cause, what happens to LH, FSH? Low. So it's very, very important that you remember these causes and you remember what happens to LH and FSH in these cases. Very, very important, right? I hope all of you have understood secondary amenorrhea and its diagnosis based on LH and FSH. Yes? Okay. Next, not a cause for secondary amenorrhea. Turner syndrome, Kalman syndrome, Sheehan syndrome, and Fragile X syndrome. So sorry, it has to be a cause for secondary amenorrhea. Which of the following is a cause for secondary amenorrhea? Answer is C. Yes, all of you know that. Then, so amenorrhea, it's very important that you revise these tables whenever you are doing amenorrhea. Coming to infertility. Morphology criteria for semen analysis as per WHO parameter is, and again, this is an INI CET 2021 question, right? So what is the morphology criteria for semen analysis as per WHO parameters? All of you, I mean, maximum, most of you are giving the right answer, and it is 4%, right? So please remember that when we talk about WHO parameters of semen analysis, we are talking about the minimum which is required for conception. We never tell that these are the average values. Hum kabhi nahi kehte these are the average values. We say this is minimum which is needed for conception, right? So sperm volume, which is minimum needed for conception, is more than equal to 1.5 ml. If there is no semen, then it is called as aspermia. pH is more than 7.2. Total sperm count is 39 million per ejaculate. Sperm concentration 15 million per ml. If sperm concentration is less than 15 million per ml, that is oligospermia. If it is less than 5 million per ml, it is severe oligospermia, right? And if there are no sperms in semen, it is azoospermia. Total motility is 40%. Progressive motility or forward motility minimum which is needed is 32%. If the sperm's motility is decreased, it is asthenospermia. Morphology, as per the strict Tiger-Burke criteria, morphology minimum 4% should be normal. If more of the sperms are abnormal, that is called as teratospermia. Vitality, 58% sperms should be viable. And if less than them are viable, it is called as necrozoospermia, right? Now, 3 very important things which I want to tell you here. Asthenospermia. In which condition you get asthenospermia? In immotile cilia syndrome, that is Cartagener's syndrome. In Cartagener's syndrome, you get asthenospermia, right? Then azoospermia, in which condition do you get? There are 2 very important conditions which you have to remember for azoospermia. Cystic fibrosis, you get azoospermia. And in Klinefelter's syndrome, 47XXY, right? So in Klinefelter's syndrome, you get azoospermia. In cystic fibrosis, you get azoospermia, right? If they ask you what is the normal or the average sperm count, they are not asking you WHO parameter for minimum. They're asking you normal or average sperm count. Then average sperm count is 60 to 100 million per ejaculate, right? If they ask you which is the most important criteria for conception, please, no confusions. What I'm teaching you, you have to follow that. The most important criteria for conception is sperm morphology. If sperm morphology is not given, then sperm motility and then sperm concentration. No confusions here at all, right? Clear to all of you? So again, just one more thing which I would like to add over here. If they ask you, what is the management? What is the management of oligospermia? With a sperm count between 10 to 15 million per ml. The management is IUI, intrauterine insemination. So minimum sperm concentration which is needed for IUI is 10 million per ml. Only if sperm concentration is 10 million or above, you can do IUI, not below that, right? If it is between 5 to 10 million, then IVF. And if sperm count is less than 5 million per ml, then ICSI. What is ICSI? Intracytoplasmic sperm injection, right? Even in azoospermia, the management is ICSI, right? And in case of asthenospermia, management is ICSI. In all these conditions, management is ICSI. Clear to all of you? Yes? Now, question number 13. Smita is a case of infertility. What is the right time in her menstrual cycle to do endometrial biopsy? Option A, 12 to 14 days. Option B, 17 to 19 days. Option C, 20 to 22 days. And option D, 3 to 5 days. So what is the best time? I'm seeing most of you are answering this correctly. And yes, the answer is 20 to 22 days. Again, I am making you draw a table where you are going to write the test for infertility or time to perform and the time to perform the test, right? So test for ovulation, including endometrial biopsy, whichever test you do for ovulation, for example, cervical mucus study or vaginal smear All the tests for ovulation, they are done on day 20 to 22 of the cycle. Either in the options, it will be written as day 20 to 22 of the cycles, or it will be written as 1 week before the period, right? So either it will be 20 to 22 day, or it will be 1 week before the period. Then why at this time you do test for ovulation? Because this is the time when maximum progesterone is produced. And that is why these tests have to be done at this time, right? If you have to do follicular monitoring, that means I am monitoring the size of the follicle and I'm seeing when it is growing and when it is bursting, when it is ovulating, then that is called as follicular monitoring. Follicular monitoring should begin from day 10 of the cycle, and you should do it on alternate day, right? Then HSG. HSG, you are putting a dye inside the uterus, and then you are doing X-ray. So you should never do it after ovulation. You always have to do it before ovulation. Best time is day 10 of the cycle. Range is D7 to D10 of the cycle, right? Then serum FSH levels and serum anti-Mullerian hormone levels. These are the tests which you do for ovarian reserve. When you want to see whether follicles are present in the ovary or not. And just now I told you, if there is ovarian failure, serum FSH levels will be increased. And how much increased? More than 40 international units. So when do you do this test to see whether ovary has follicles or not, whether ovarian failure has happened or not? You do it on day 2 or day 3 of the cycle. Whereas if I want to check serum anti-Mullerian hormone levels, please remember that in ovary, there are follicles. What is a follicle? So this, what I have drawn is a follicle. A follicle is a primary oocyte, which is surrounded by granulosa cells and theca cells, right? Now, the granulosa cells of the follicles from puberty onwards, these granulosa cells, they secrete estrogen. So estrogen comes from granulosa cells. They secrete inhibin and they secrete anti-Mullerian hormones, right? Now, that is why granulosa producing tumors of the ovary, right? Granulosa cell tumor of the ovary, it is estrogen producing tumor because granulosa cells produce estrogen and their tumor marker is inhibin, right? Now, this means the less are the number of follicles, less will be the levels of anti-Mullerian hormone. So in case of ovarian failure, the levels of anti-Mullerian hormone will be decreased, whereas the levels of FSH will be increased. Why the levels of FSH will be increased? Because estrogen will be less, inhibin will be less, so negative feedback on FSH will be gone, so FSH will be high. So in all cases of ovarian failure, that means when no more follicles are left in the ovary, FSH is high, anti-Mullerian hormone is less. Out of these two tests, FSH has to be done on day 2 or day 3 of the cycle, and AMH has to be done on any day. So if I ask you which is the best test for ovarian reserve, you will say, ma'am, AMH. Why? Because AMH can be done on any day of the cycle, right? Then there are certain females in whose cervix antibodies against sperms are present. So if I want to know anti-sperm antibodies are present or not, if I want to know anti-sperm antibodies are present or not, the test which we do is post-coital test. And post-coital test has to be done between day 12 to day 13. Range is day 12 to day 15. So I'm repeating, all the tests for ovulation, including endometrial biopsy, whether they say serum progesterone levels, whether they say cervical mucus study, whether they say a vaginal epithelium study, all the tests have to be done on day 20 or day 22, which means 1 week before the period, right? Follicular monitoring has to be done from day 10 of the cycle. HSG has to be done between day 7 to day 10, best is day 10. Then test for knowing whether follicles are present in ovary. That is serum FSH levels. Serum FSH levels will be high and they will be seen on day 2 to day 3. Serum AMH levels will be low and you can do it on any day. And post-coital test is done between day 12 to day 13. Best is day 12 to day 13. It could be done between day 12 to day 15. Clear to all of you? Yes? Now, next question. An infertile 28-year-old lady comes for workup. Her ovulation tests are normal. So if her ovulation tests are normal, I know she's not a case of an ovulation. Anti-Mullerian hormone levels are normal. That means her ovary has enough follicles. Now I wanted to see her tubes. So HSG was done. And the following image is seen. What is the next step in investigation? Before you understand this HSG, please remember that for tubal infertility, the investigation of choice is HSG, but the gold standard investigation is laparoscopic chromoperturbation. Laparoscopic chromoperturbation. In laparoscopic chromoperturbation, you will put a laparoscope and in the uterus, you are going to put a dye. And from the laparoscope, you're going to see whether the dye is coming out or not. Along with that, laparoscopy will show you the exterior of the tube. HSG cannot show you the exterior of the tube. That is why HSG is investigation of choice, whereas laparoscopic chromoperturbation is gold standard, right? Now, if you are getting an image like this, this means the dye is going from here. It is going into the uterus. It is going up till the angle of the uterus, but it is not coming beyond it. That means there is a bilateral cornual block. Now, if you get a bilateral, see, this is normal. Normally, you should have got a spillage like this, which you are not getting here. It means the dye is not going beyond the angle of the uterus, right? So in this case, if you are getting a bilateral cornual block, the most common reason is cornual spasm. That means when you are putting the dye, because of the pain, the tubes, the proximal end of the tubes, they undergo spasm, and which doesn't lead to passage of dye. So it appears like a block. There is no block. Because of the spasm, the dye is not going, right? So in this case, what I should do is I should take a thin wire, and with the help of hysteroscopy, I should pass that wire inside the tube. This is what is called as hysteroscopic cannulation. Hysteroscopic cannulation means I will take a thin cannula, and with the help of hysteroscope, I will look inside the uterus and I will pass this thin cannula, followed by laparoscopic chromoperturbation, right? So now I will not do HSG again. I will do the gold standard test, that is laparoscopic chromoperturbation. By doing this much, most of the blocks are resolved. But if block is not resolved, then it means that this blockage is due to some pathology, and most of the times it is due to genital TB. And so best management becomes IVF. For tubal blockage, always best management is IVF. For any kind of tubal blockage, best management is IVF. So please read your questions very carefully. If they ask you that there is a case of bilateral cornual block, what is the most common reason? Most common reason will be physiological, right? Number one. If they ask you what is the next step in management, next step in management will be laparoscopic chromoperturbation and hysteroscopic cannulation. So instead of writing this big thing, sometimes they will just write hysteroscopy and laparoscopy. But if they ask you what is the best management is IVF. Similarly, if they ask you what is the most common cause of bilateral pathological cornual block, So when the word pathological comes, I'm not going to say cornual spasm or physiological. Now I have to say it is due to genital TB, right? So look here in this question, what they were asking. in this question, they had given you a slide of bilateral Cornwall block, right? And they are asking you next step in investigation. So next step in investigation will be laparoscopy and hysteroscopy. That is laparoscopic chromoperturbation and hysteroscopic cannulation. If the question would have said, what is the best management? Then my answer would have been IVF. Clear to all of you? Yes. Now I also want you to look at the second HSG. The second HSG is showing that the dye is coming, yes, inside the fallopian tube, right? It is going, filling the fallopian tube, but it is not spilling out. There is no spilling. Here also there is no spilling. The fallopian tube has become dilated, but the dye is not coming out, right? This is what is bilateral fimbrial block or distal block with hydrosalpinx, right? So there is fluid which is toxic, and this hydrosalpinx fluid is toxic, right? So it is present inside the tube. And this is what is bilateral fimbrial block or distal block appearance. Now, again, the diagnostic test will be laparoscopic chromoperturbation or simply laparoscopy. What are you going to do for management? Now, when I'm going to do laparoscopy, simultaneously, if it is a mild block, I will treat with laparoscopy, like I will do fimbrioplasty, or if adhesions are present, I will do adhesiolysis, if it is a mild block. But if it is a severe block, then I told you, in severe cases of tubal blockage, always the best management is IVF. And whenever hydrosalpinx is present, it means it is severe, right? So whenever hydrosalpinx is present, it means it is severe. So if they show you this image, right, it means it is severe, and you have to say management is IVF. The other thing what you have to remember is that when I'm going to do IVF, I'm going to put the zygote here, right? And I'm just now telling you that hydrosalpinx fluid is toxic. So this hydrosalpinx fluid can come inside the uterus and it can be toxic to the zygote. So before I do IVF, what am I going to do? I'm going to cut these tubes. These tubes are as it is useless. So I'm going to cut these tubes. I will do salpingectomy and then I will do IVF. So I'm repeating what I said. If hydrosalpinx is present, it means it is a severe block. And that means you have to do IVF. But before you do IVF, you should remove the tubes because these tubes have got toxic fluid. And this toxic fluid can come inside the uterus and harm the zygote, which I'm going to put. So before IVF, I'm going to remove the tubes, cut the tubes, that is, I'll do a salpingectomy, and then I'm going to do IVF. Clear to all of you? Yes? Please in your chat box write yes if you've understood. Okay. Then comes the last question for the session, which is related to your vaginitis and PID. And this is an OBGY and PSM integration, right? A 30-year-old female from a nearby village comes to PHC due to pruritus in vaginal region, discharge and dysuria. She's sexually active and has no medical conditions and has no medical allergies. Her BP is 130/84, temperature is 98.9. Speculum examination reveals curdy white discharge and excoriation of vaginal wall. A saline wet mount examination reveals thin thread-like structures. Which of the following is the best management option for this patient? Now, in this case, I know all of you have made the diagnosis. Tell me, what is the diagnosis? The diagnosis is? What is the diagnosis? First, tell me that. Excellent. The diagnosis is candidiasis. Patient coming to you with pruritus, with dysuria, and the discharge being curdy white discharge, which excoriation of vaginal wall, and on saline mount, you are getting thin thread-like structures. It has to be candidiasis, right? And what is the drug of choice for candidiasis? Drug of choice for candidiasis is fluconazole, right? Fluconazole, 150 mg stat. This you give in non-pregnant females. In pregnant females, what am I going to do? In pregnant females, tell me, what am I going to do? Excellent. In pregnant females, you are going to give clotrimazole cream, topical clotrimazole, right? So that is what you do in pregnancy, right? You are going to give miconazole or clotrimazole cream in pregnancy. Now, here they are not asking you this. Now they are asking you, what kit are you going to use? So please remember, there are total 6 kits which you have to remember. Out of those 6 kits, 3 kits you have to remember from in gynae, 3 you will be taught in skin dermatology, right? The 3 kits which you have to remember for gynae are gray kit, green kit, and yellow kit. Kit 1 is gray kit. This you are going to give to any female's partner, right? So whenever a female comes to you with PID, to partner you have to give kit 1, that is gray kit. Kit 2, that is green kit, you give in case of vaginitis, right? And in vaginitis, we have bacterial vaginosis, Trichomonas vaginalis, and candidiasis. So candidiasis, the treatment is fluconazole. So this kit has got 1 tablet of fluconazole. Bacterial vaginosis and trichomonas normally we treat by metronidazole. But this kit doesn't have metronidazole. This kit has secnidazole, 1 gram, 2 tablets. Clear to all of you? Yes? Okay. Then comes kit 3. Kit 3 is for PID. The third kit which you have to remember, that is kit number 6. It's not kit 3. The third kit which you have to remember in gynae is the yellow kit, that is kit number 6. And this 6 number kit, which is the yellow kit, is used for PID, and it has got cefixime tablet, it has got tablet metronidazole, and it has got tablet doxycycline. So cefixime, metronidazole, and doxycycline. So whenever a patient comes to you with vaginal discharge, you are not, and you are giving a kit treatment. Please remember this difference. In kit treatment for vaginal discharge, we do not treat the male partner, right? In kit treatment, we treat the male partner only if they come to us with PID, right? Yes, you are going to give kit 6 to chlamydia and gonorrhea. PID is caused by chlamydia and gonorrhea, right? So whenever you are giving kit number 6 to the male partner, you will give kit number 1. This, in case of kit number 2, if you are giving to a female, you will not treat the male partner. So in syndromic management, we treat the male partner only if we are treating PID. That means if we are giving female kit number 6. Normally, when you treat vaginitis, I'm not talking about the syndromic management, the kit management. Normally, when you are treating vaginitis for Trichomonas vaginitis, you treat the male partner, right? But not in syndromic management. Clear to all of you? Yes? So this is all what I have for today. Now, if you have any queries, you can quickly ask me in the chat box. When will the Marrow Edition 5 revision videos be available? Very soon. Very soon they would be available. Any other academic slide number 27? Which was the slide number 27? Let me see which was slide number 27. This was slide number 27. Ma'am, can you please repeat partner treatment? Okay, Parul, see, there are 2 types of managements. One is when you are treating a Trichomonas vaginitis, and we are not talking about kit treatment, right? We are just saying that, are you going to treat the male partner in Trichomonas vaginitis? Your answer will be yes. If I ask you that for Trichomonas vaginitis, you are giving kit number 2 to the patient, are you going to give any kit to the male partner? No. So when you are doing kit treatment, you do not treat the male partner for vaginitis, right? You treat the male partner only for PID when you are doing kit treatment, right? Okay, then primary amenorrhea without secondary sexual characteristics is 15 or 16, 15 years. 15 years. Question number 1, 2, 3, 4. Okay. Question number 1. Don't get confused about important topics. Whatever webinars I'm taking only on important topics. And if you can see, I am concentrating only on high yielding points, right? Table of primary amenorrhea. I'll just repeat the entire session. I'll just show the slides of entire session, right? Click pictures if you want to quickly. Jawahar, just now I'm also saying that investigation of choice is 3D ultrasound. Just now also it's the same. Investigation of choice is 3D ultrasound. Gold standard is MRI. Bilateral fimbrial block. Okay, bilateral fimbrial block. Let me come to it. I'll explain you. Next session is on 3rd of September. Ashwini, I don't know whether these PDFs are being made available to the students or not. That is why I am showing you these slides so that you can copy. Edition, you're asking about obs and gynae, YouTube FMGE revision or edition 4 revision? YouTube FMGE revision. Because rather you should wait for edition 5 revision videos, because all updates are present in edition 5 revision videos. Yes, Lubana, last kit question's answer was green kit. Sorry if I did not say green kit, it's green kit. Swyer's syndrome. Just now it will come. Just keep clicking the pictures, it will come. Specific treatment. See, these kits are given by government, right? So if you are in PHC, if you are in a rural place, if you are in a government hospital, you will give these kits. When you do private practice, you are not going to give kits, right? Luteal phase defect. See, luteal phase defect, as the name suggests, luteal phase means the second half. And in second half, what is the main hormone? Progesterone. So what does luteal phase defect mean? That there is less progesterone, right? And because of that less progesterone, how is patient going to present to you? With recurrent abortions. So I'm just showing you these slides. How to approach marrow for OBG. The best way is, before you come for this session, revise the topics which I tell you, and then the next session topics, they are already decided. Just let me tell you. Next session topic are next session, as I told you, it's on 3rd of September, and contraception, disorders of sexual development. That is, we will talk about, external genitalia and all those problems, ambiguous genitalia, pseudo-hermaphroditism, and prolapse. Sterilization techniques are not important. No need to go for sterilization techniques. Just you should know about Pomeroy's technique. That's it for FMG point of view. Laparoscopic instruments are important for laparoscopic sterilization. Yes. So that is why vaginal cytology you will not do before 14 days. Malhar, if you do vaginal cytology before 14 days, what do you want to see? That is why I told you na, that you have to do test for ovulation on day 22 of the cycle. MCI, I don't know. I mean, sometimes they ask gynae more, sometimes they ask obs more. So don't ask me this question, obs is more important or gynae. SLE, torch infections, and thyroid disorders, no. No, they are not important for FMG. Instrument slide. Hilal, which instrument slide are you talking about? So this was your fimbrial blockage slide, and I was telling you if there is a mild fimbrial block, I am going to do fimbrioplasty. But if there is, severe block, which is manifested by hydrosalpinx, these tubes, dilated tubes, mean hydrosalpinx, and that means severe block. In that case, you have to do IVF. But before you do IVF, you should cut these tubes because the fluid which is present in a hydrosalpinx is toxic, right? In endometriosis, we did yesterday, Mithila, the investigation of choice we did the other day. In the investigation of choice is laparoscopy. Gold standard is histopathological examination. No, FMG YouTube session is not enough for FMG, but yes, that is, you have to revise that much plus MCQ discussions, what we are doing now. Right. So this is all. You will get session on all topics, all important topics. You will get sessions. Don't worry. I will do session on cancers, but next time the session is on contraception, disorders of sexual development, and prolapse. Okay. Thank you all also so much. Take care and keep studying, and please keep practicing your MCQs. That is what is very important. Okay.
Thank you, ma'am. Thanks a lot.
Thank you.